participants.
Hope the conference is going great.
Yeah. We are all ready, sir.
Yes, sir. Can you hear me?
We can hear you, but it's not very loud.
Yeah, just a minute. He's connecting.
Can you speak again?
Yeah, he's connecting, sir. Audiovisual guy is connecting in a minute.
Okay, okay.
Hello.
Hello.
Yes,
Yes,
sir. Am I audible, sir?
yes, you are audible.
So good morning, everybody.
Good morning. You are audible and visible as well.
Oh, thank you. So I hope the conference is going great in Islamabad.
It's really going great. We have an excellent weather here and excellent atmosphere with excellent participants.
Oh, really great. So we are all set for today's demonstration. So before we start, anybody has any question or something for the yesterday's presentation demonstration?
Yes, we do have a question from Professor Ajmal.
Yes, please.
Satish, I just want to know, you once tried to tell us a trick about the collateral wand, that you removed some pin from it so that it doesn't choke during suction.
Yes, yes, yes. So what happens?
If you can
The,
tell us.
the suction port of the carburetor vent, is divided into two parts by a titanium chip, which is practically of no use and unnecessarily narrowing the suction channel. So, when you, remove the tissue, once you particularly ablate, as the tissue goes in, it clogs the suction channel. And, repeated clogging is something which is, not good for the temperament of the surgeon, as well as for the surgical process, as it violates the fields. So, what we do, we remove the uh, you know, the titanium chip between the two suction ports. The suction port is divided into two by a thin titanium chip that is only on the surface, not in the depth.
Okay.
So if you remove by a wire cutter, your suction port really becomes big and it rarely clogs. Yesterday you saw in the entire case, not even once the suction port was clogged.
Yeah. We
So
noted. Thank you.
So that is really useful, sometimes, particularly in extensive cases where you need a high power suction and you don't want repeated clogging and all that.
Dr. Jain, we have another question. I was meaning to ask that we do understand that the JNA does take branches in a stage 3, stage 4 from the branches of the internal carotid artery as well, more specifically from the Vidian. But as we could see yesterday, that the carotid was somewhat dehiscent, and whilst you were removing it, have you ever had an incident where there was a direct branching or angiogenesis from the cavernous ICA to the JNA. Have you ever had that incidence? Because in
Yes.
that regard, it would be difficult to just tweeze out the JNA without a major bleed. I was just wondering about it yesterday.
Yes, yes. We have seen couple of times, and it's a regular feature once JNA invades, to the skull base, particularly to the cavernous sinus and the paracavernous region. Once it invades the temporal lobe, particularly intradural, it acquires vascularity from the middle cerebral branches as well. So there are two sorts of internal carotid supplies. One in the nasopharynx, at the at the sphenoid level. The median artery also is a branch many a times from the internal carotid, sometimes from the external internal maxillary as well. So once there are extracranial branches, if there is an extracranial branch, what you can't do anything, you can't embolize it. What you need to do is you should be able to deal with that bleeding. You can anticipate some extra bleeding, you can arrange some extra blood. You have to prepare to deal with extra bleeding. That's the only thing, the importance is. Once it is an intradural branch coming from any of the branches like middle cerebral or whatever, the significance is you have to have open approach to prevent that vessel, retracted into the brain and keep on bleeding. That's a different scenario. The safety caution is very, very important in that situation. And then you have to have an open approach to catch that vessel, coagulate with that vessel, and deal with that vessel.
Thank
So
you.
these are two different scenarios of intercarotid vascularity.
Thank you, Doctor.
But in any given situation, you can't embolize. You should not embolize the internal carotid circulation branches.
Thank you.
Any more question, or do we go ahead with today's proceeding?
Sir, I think we should go ahead and we will ask if there are any.
Yes, yes, yes. So the first case today, can you connect the laptop? Let me know when you get a CT scan on screen. Are you getting any CT on the screen?
Yes, there is CT on, we can see the CT.
Yeah. So this patient had bilateral polyposis. She was operated somewhere earlier. That's a revision situation. And what we see, the CT is very important to know the extent of disease as well as the reason for the so-called recurrence and how to deal with it. See, once you deal with the eosinophilic sinusitis, eosinophilic disease, now the CRS has been, more and more classified into various endotypes. And each endotype has a different underlying pathophysiology. And understanding that fact has really improved the overall outcome of sinus surgery. And this disease is basically divided into two groups as phenotypes like polypoidal and non-polypoidal sinus disease. And non-polypoidal is not that virulent, mostly neutrophilic driven. Infection is one of the hallmark there. And the other one, the eosinophilic, which is mostly presenting as a polypoidal, that is more virulent, that is more resistant, recalcitrant disease, and chances of so-called recurrence are high if not treated the underlying cause. So to understand the underlying cause, various pathophysiologic mechanisms have been identified and different endotypes have been described. Like AFRS is a different endotype, allergic fungal rhinosinusitis. AERD is a different endotype, respiratory, aspirin exaggerated respiratory disease. The cystic fibrosis is a different endotype. Eosinophilic sinusitis is a different endotype because the underlying pathophysiological mechanism is altogether different. And to understand and treat that mechanism is the main hallmark of treatment rather than relying for a cure on surgery. So now that the goal of sinus surgery has been redefined. The goal of sinus surgery has been redefined in the sense earlier when Messer-Klinger and Stamberger defined the role of sinus surgery was just to open up the sinuses to establish ventilation and drainage. it works very well, and it has been, still it is a goal of the sinus surgery. But that is not everything. In the past, that was taken up. What Messerkinger and Stamberger did was widely accepted, and people went in doing, worldwide sinus surgeries everywhere. And they got good results, but after a period of time, majority of the patients face the recurrences. And that so-called recurrences, you know, made the researchers work into the region what this kind of disease is, what actually the disease is at the molecular level, and then more and more work at the research level has been done in past 3 decades to understand this disease more and more, and a lot of things have come out. So now the goal of surgery has been redefined, as this has been defined as a immune modulation disease, inflammatory disease. This is not infection. This is inflammatory disease, mostly eosinophilic driven disease with a lot of endotypes with different underlying pathophysiologic mechanisms. So now the goal has been redefined, and most, on the entire cascade of, sinusitis development, the only weapon we have now in the present era which works is the steroid. So steroid is the mainstay of treatment in most of these, polypoidal sinusitis, the recalcitrant disease. But we all know in our hearts and hearts, we can't give steroid to our patient for long run. How long we can give steroid? They have their own adverse effects. So now the strategy has changed. The role of surgery has been redefined to different goals. Number one, obviously to establish the ventilation and drainage, open up all sinuses to establish the natural ventilation and drainage. Number two, to remove the inflammatory load. The polyp is an inflammatory load. That is the eosinophilic load. You need to remove that inflammatory load so that your topical treatment, the next goal is to introduce the topical steroids inside the sinuses, deep inside the sinuses, the area where the steroids are needed. Rather than giving oral steroids, the topical steroid can work yet without systemic side effects. That's the third goal. So now the goal of surgery is to ensure that steroid reaches everywhere. This is one of the main goals. So you can train your patient post-operatively that how to introduce the steroids in the sinuses to make sure it reaches everywhere to all sinuses. That is one of the main goals. Otherwise, the inflammatory disease can come back. You have to give oral steroids. The oral steroids have their own limitations. So the entire thing relies on the ability of the topical steroids to penetrate inside post-operatively, and the success of the surgery totally relies upon that. So now the counseling to the patient is not like once we operate, you'll be all right. You have to make them feel that the surgery is the beginning of the treatment, which allows the further treatment with the topical steroid to prevent recurrences. This should be very clear to the treating surgeon as well as the patient, every patient. Now, once it comes to surgical work, that's what I'm going to share with you. And today's course is an interesting one. You must have seen as you said on videos, you have seen lots of primary sinus surgery. So this is a revision sinus surgery. And see, what you need to order is a fine section CT scan in axial planes, and then you can reconstruct to all planes. I can reconstruct to all planes. You can change to window settings, to the bone window, soft tissue window, like this is bone window setting now. And you can see in different planes, different anatomy. I'm not going details of the CT scan, but certain different anatomy
Dr.
is
Jain,
explored in different planes. Yes, sir.
before you move forward, I would like to ask that, like in patients of chronic sinusitis, you routinely get levels of vitamin D checked, CRP, and eosinophil level checked. Do you do the
Yes.
same in the in nasal polyps patients as well?
Yes, that's a very important question. See the workup. Let me tell you other way around. Any patient with this polyp coming to you for surgery will definitely have one question. Doctor, do I need to get this surgery done again and again? Will my disease recur? Will it be a cure with your surgery? You have so many questions thrown and you don't have any answer. Because you don't know the individual patient's disease profile, inflammatory profile. As I said, this is an inflammatory disease, steroid dependent disease most of the time, and the immune complex disease, immune mediated disease. So the, it has been now widely accepted that anything which improves your immune system overall will have a positive impact on the overall outcome. Anything which has a negative impact on the immune system will have a negative impact. So, in order to improve the overall immunity, you need to do certain things, you need to check certain things, because in spite of the best work done sometimes, if your immune system is not supporting, the patient may not get the desired outcomes. So, in order to improve the immune system, there are certain tests need to be done. Like, for example, the eosinophilia. Eosinophilia is the single most important determinant factor. If there is too much of mucosal eosinophilia, which is sometimes corroborating with the serum eosinophilia as well, then the chances of recalcitrant disease are more. Because eosinophil disease is more and more resistant disease and it requires more and more high doses of steroids. So if the patient has a significant mucosal eosinophilia, you can counsel pre-op, per-op or post-op that you need more, long-term, more judicious use of steroids, more use of steroids, and more overall, post-operative treatment, regular follow-up. All these things is required more extensively as compared to the less eosinophilic patient. Similarly, like vitamin D you mentioned, is one of the important, determinant of immune regulation of the nasal immunity. So those patients having severe vitamin D deficiency, it has been studied so well, may not have a good outcome, and that is something you can easily get the test done and replenish and to improve the overall immunity. A smoker, you can tell them to quit smoking, otherwise their mucociliary function is not as good as compared to the non-smokers. Anything which improves the immunity, and it has been very widely well accepted, known fact that our gut microbioflora is the main determinant of overall human body immunity. We have more than 3-4 trillions of bacteria in our gut. The good bacteria, which maintains homeostasis in the body by means of regulating the immune system. So, in order to improve the immune system, we have to improve those good bacteria, and that you can improve by two ways. One is by adding the number of good bacteria in terms of giving probiotic. Probiotics are like bacterial strains, basically. The good bacterial strains to improve the strength of good bacteria. As you have a good number of and rich and diverse number of good bacteria, the chances of pathogenic bacteria growth is automatically reduced. Other way of improving the good bacteria is to provide substrate to the good bacteria, that is prebiotics, to improve the growth of good bacteria. So prebiotic and probiotic are essential part of the supplement in the overall management in the to improve the chances of the desired outcome in sinusitis, in CRS. So anything which improves your immunity, by and large, you need to look into it. If patient has any immune disorder, systemic immune disorder, ciliary disorder, will have a significant bad impact, negative impact on the overall outcome. So all these things has to be studied earlier. Otherwise, post-operatively, if you get to know and tell your patient, no, we have operated, but we have found this kind of disease, you may not have a good outcome, you may need